Hello, everyone, and welcome. I'm Kathy Donaldson, the Program Coordinator of the Perinatal Mood Disorders Initiative at Central Jersey Family Health Consortium. I'm glad you could join us today for the second webinar in the Maternal Mental Health is the Heart of the Family webinar series. I hope you can join us each week as we commemorate Maternal Mental Health Awareness Month. Each webinar will be recorded and will be available on our website and on YouTube. Please put your questions throughout the session in the chat, and we'll get to as many of them as we possibly can at the end of the session. And now I'd like to introduce Dr. Laura Kelly, our speaker for today. Of the Perinatal Mood and Anxiety Disorder Center at RWJ Monmouth Medical Center in Long Branch, New Jersey, and also at Yad Rachel in Lakewood, New Jersey. She's also the program director of the Psychiatric Mental Health DNP program at Columbia University in New York City. She has more than 20 years experience in the treatment of women with psychiatric issues before, during, and after childbirth. Dr. Kelly will speak to us today on the use of medications in the treatment of perinatal mood and anxiety disorders. And now, please join me in welcoming Dr. Kelly.
Thank you, Kathy, and welcome everyone to an update on the use of psychiatric medications during, before, during, and after pregnancy. There we go. Sorry about that. So before we begin, just a couple of minutes to talk about the Perinatal Mood and Anxiety Disorder Center at Monmouth Medical Center. I'm sure most of you are aware of our program, but we do offer services for pregnancy planning as well. So if you identify clients in your practice who have mental health issues or are currently being treated for mental health issues, then certainly if they're thinking about pregnancy and would like to discuss that with a mental health provider prior to getting pregnant, that would be wonderful, because what we're finding is that many mental health providers are still insisting that clients come off their medication before pregnancy, and this really creates a lot of discord and anxiety around getting pregnant, when that may certainly not be necessary. When we think about depression during pregnancy, between 10 and 20% of women will experience significant depression during their pregnancy, and oftentimes, about a third of these women, it will actually be a first episode of depression. Well, we certainly know that there are some risks to taking medication during pregnancy. There's also a lot of risks of untreated depression during pregnancy. And some of those risks are low birth weight or small for gestational age infants. There are obstetrical risks, such as higher rates of miscarriage, preterm labor, placental abruption, and preeclampsia. We can see irritable babies based on having them been exposed to very high cortisol levels throughout the pregnancy because of the mental health issues and the stress of the mother. Oftentimes, this can result in lack of adequate prenatal care if mothers are so depressed that they can't get themselves to care during their pregnancy. Also, a higher use of alcohol and drugs. And what we also know is that untreated pregnancy depression certainly carries into the postpartum. So we have subsequent postpartum depression and also subsequent recurrent episodes of depression. And the risk of suicide is also high. So what in the world do we do about moms who are depressed during pregnancy? Well, first, obviously, we need to assess them for depression during pregnancy. And most of us know, especially those of us that are treating mental health disorders with women, that pregnancy is not necessarily a time for glowing happiness, right? Is the client depressed during pregnancy? Does the client have a history of depression prior to pregnancy? Is the client being treated for depression or had been treated for depression before the pregnancy? Certainly assessing their mental health is very important to ascertain whether or not treatment might be necessary. We want to assess the overall risks through evaluation of the patient's history. What are the current risk factors and what is the current presentation? If they just came off their medication when they found out they were pregnant, then they certainly may not yet be displaying symptoms of depression, especially if they just came off, because the medication does not necessarily leave their system the day they stop it. When we think about women who have mild to moderate depression, we always want to try non-pharmacologic interventions first, and that may include things like exercise, sleep, good diet, social supports, maybe online or in-person mom support groups. Certainly therapy is helpful for depression, mild to moderate depression. We also want to have an open discussion with the mom about the risks and benefits of treatment with medication for depression during pregnancy. And also making sure the mom understands the risks of inadequately treated depression during pregnancy, what the outcomes can be. For women who are stable on antidepressants and wish to discontinue antidepressants, we really want to understand the reason why they want to discontinue the risks. Have they been educated adequately on the use of medication during pregnancy? Where are they getting their information from? Have they been educated adequately on the risks of untreated depression during pregnancy? But if they are insistent upon coming off antidepressants, then we really want to monitor them closely and intervene at early signs of recurrence. And I have lots of moms who really want to try and come off their medication prior to pregnancy. And these are the perfect type moms to have at the PMAD center, because we can really monitor them very closely. Oftentimes I'll see moms monthly who decide to come off their antidepressants and if they've been stable on them prior to pregnancy and they want to come off during pregnancy. But we can intervene early and get them back on meds if necessary as quickly as possible, so as not to create too much distress for the mom. When the decision is made to continue to use medication during pregnancy, we want to select medications with the best established safety profile. And the good news is that we have a significant clinical information at this point with the utilization of most psychiatric meds to help moms make informed choices about choosing the best medication. Medication decisions should be guided by the patient's history of prior medication treatment. If a woman is already on an SSRI antidepressant that is working, we want to continue the mom on that one. It's not a time to change antidepressants and risk relapse and then exposure to more than one drug. If a mom comes in and has been taking Prozac for 5 years and has been stable on Prozac, there's absolutely no good clinical reason to say to her, you should really switch to Zoloft, right? Because there's more clinical evidence. What we know is that if the mom is stable on an SSRI, changing to another SSRI does not make sense. Now, when moms who are now consumers and are Googling everything and talking to people and hear that, there's more clinical evidence using Zoloft than any other drug, and the mom is stable, then it's a hard sell to try and convince them to not switch antidepressants. But the truth is, if you switch antidepressants and there's a relapse, then we're going to have to switch back anyway. And then we've exposed the fetus to more than one medication and also have given the mother a time of depressive or anxiety symptoms that certainly would not have been necessary had they stayed on the medication they were on to begin with. Tricyclic antidepressants are safe. Nortriptyline is the preferred because there's the most clinical evidence, but the side effect profile of any of the tricyclics is so much greater than the side effect profile of SSRIs that it certainly wouldn't be our first choice. But if I have a mom that comes in on nortriptyline, I would not say, okay, then we should switch you to an SSRI. That wouldn't make sense if the mom is already stable. We also need to use an adequate dosage. Sometimes that means we would have to increase during pregnancy because of the increased blood volume. We wouldn't necessarily decrease. However, if I have a mom that comes to me that has been on Zoloft 100 milligrams, let's say, for 5 years and has not changed the dose and really wants to see how they would do on a lower dose, I would not hesitate in working with the mom at decreasing the dose, because sometimes just psychologically, if they can be at 75 milligrams during pregnancy rather than 100 milligrams during pregnancy, they feel like they're taking action to create the safest environment for their baby. Although clinically speaking, there's really no difference between 175 when we look at placental crossover. It's really, but sometimes just giving the mom, a feeling of control and a feeling of doing something to decrease the dose psychologically is very helpful. So I often do that. Certainly, mothers with severe depression and histories of depression that are not responding to medications, ECT or TMS have been used successfully in these moms. I have a mom now actually who's, although there's not as much clinical evidence for TMS use during pregnancy, it's not contraindicated. I have a mom now going through TMS treatments and with good results. She's finished her 17th treatment. I think she has about 6 more to go and is doing quite well. So it's been helpful for her. She had a long history of depression with no response to medications. So what about SSRI use during pregnancy? Really, we have lots and lots of data now. And recent findings and more data inform us that really pharmacologic treatment of depression during pregnancy is indicated and safe. Consistent conclusions that the absolute risk of SSRI exposure in pregnancy is small. There are recent case control studies that reveal inconsistent data regarding the teratogenicity risk of individual SSRIs, and reproductive safety data on SSRIs exceeds what is known about most medications used during pregnancy. And let me stop here for 1 second. My source of information outside of the clinical literature is Reprotox, which is what the database we use at the PMAD Center, which is one of the largest databases of medication collections of drug use during pregnancy. It's updated monthly. In general, for the treatment of anxiety and depression, SSRIs are the most commonly used. Well, why is that? Because the side effect profile on SSRIs is the safest. And SSRIs can be and are prescribed more commonly by non-mental health professionals because they are safe. And the side effect profile is minimal. So many people get SSRIs prescribed by their internists or primary care providers or their OB/GYN providers. There are potential complications of SSRIs might include maternal weight changes and premature birth, but most studies show that SSRIs aren't associated with birth defects. There was a study years ago looking at Paxil being associated with an increased risk of a fetal heart defect. As such, it's generally discouraged during pregnancy, not necessarily because of the risk of fetal heart defect, but because of the options of using other SSRIs and the bad press that Paxil has gotten, that we avoid using it during pregnancy. However, if you have a client that is doing well on Paxil, switching them to another SSRI, again, does not necessarily make sense. And here you see that the absolute risk versus the general risk of a first trimester heart defect is really very, very small. There's really not a lot of evidence to support an increased risk of cardiac malformations. But again, since if you're starting from scratch and you have other options, it doesn't make sense to choose Paxil when we have other options to use. What about non-SSRIs during pregnancy? Well, there's some data, but it's more limited when we look at medications such as venlafaxine and duloxetine during pregnancy. But we certainly have, that's a building body of literature. And I've had a number of clients on Cymbalta throughout their pregnancy because of long histories of SSRI failure. that they've done much better on the effects and the Cymbalta, and have, clinically, anecdotally done perfectly fine. The data on the Wellbeing includes a growing number of exposures, again, supporting the absence of any increased risk for malformation. There's some concern of a small risk of withdrawal seizures in babies who've been exposed to high dosages of Wellbutrin during pregnancy, although that relative risk is also quite small. When we look at this poor neonatal adaptation, something that I also refer to as cranky baby syndrome, and this is a subject that comes up a lot, where a lot of OBs would like to decrease the SSRI dose in the last trimester to decrease the risk of transient irritability, agitation, jitteriness, and tachypnea in newborns. But the studies looking at this data really do not control for the maternal mental health condition. So, if we are discontinuing or lowering the dose late in pregnancy, aiming at reducing the risk of neonatal toxicity, you're also increasing the risk of mother having a depressive relapse in the postpartum period, and the risk of the neonatal adaptation syndrome is really quite small. There's really no correlation between measures of umbilical cord blood levels of SSRIs and the risk of developing neonatal symptoms. Other studies have shown no difference in symptoms between two groups compared with infants born to moms who had taken SSRIs but tapered versus those who continued. And lowering the dose of antidepressants increases the risk for maternal postpartum depression. And what we have to understand is, in working with moms at the PMED Center who come from all over New York and New Jersey for treatment, is that they trust their OBGYN providers, and if the providers really are insistent about them decreasing the dose, it's highly likely they're going to decrease the dose regardless of what I encourage them to do. So we try to decrease the dose as minimally as possible, so that, again, the mother feels like they're doing the right thing and taking some control. But we don't encourage them to decrease the dose in that last trimester of pregnancy, especially if they've been stable throughout the pregnancy. As we know, that first 72 hours of hormonal plummet can be very difficult for the moms to begin with, and if we decrease their medications, we're increasing the risk of them struggling after those 72 hours. But neonatal adaptation, while it sounds terrible, and I'm not encouraging that this is a good thing, it's self-limiting to the newborn, and it creates some irritability, which is, again, self-limiting. The risk for pulmonary hypertension of the newborn with late trimester exposure to SSRIs, and I left the studies on here. And I'll supply the rest of the references, is that there's really been inconsistent findings to whether or not PPHN is really related to late trimester exposure of SSRIs. In the 20 years that I've been treating moms during pregnancy, and when I think about the 20 years of treatment when I first started, there was very little use of any medications other than Zoloft. And the evidence for the PPHN was limited because of the amount of studies that were being done. I've, thank goodness, never seen a case of PPHN with any of the moms that I've treated with SSRIs. And interestingly, the one mom that did have a baby with PPHN refused medication during pregnancy, so she was not on any medication and still had a baby with pulmonary hypertension. So we can't, first, the risk is very, very low. And again, I try to avoid starting SSRIs in the third trimester, if I can. But if we can't, and if the mom is symptomatic, then we certainly would start them. What we do know is that SSRI use versus untreated depressions in moms is that both continuous untreated depression and continuous SSRI use is still associated with a 20% increase in risk of preterm birth. So if the mom has not been treated for her depression, she's still at risk for preterm birth, more at risk than a mom who is not depressed, versus the same risk if they're on the SSRI. So if a woman taking an SSRI and is not depressed, it goes into preterm birth, the postpartum period would be easier to manage than a woman who has a preterm birth and is treated for her depression or her anxiety. And again, women taking SSRIs versus those with psych histories versus controls, those taking SSRIs had a higher risk of preterm birth, but only by 5 days. Depression, SSRI exposure, and stopping SSRIs during pregnancy have been associated with increased spontaneous abortions in the first trimester. This is always a question that moms ask. They're not, if we're not worried about taking the medication during pregnancy, what about our children having been exposed during pregnancy? What is the neurobehavioral effects, the long-term effects of children who were exposed during pregnancy to medications? And obviously, when you think about looking at children long-term and the intervening variables that happen once a child is born, it's very difficult to isolate simply the medications exposure during pregnancy. But there have been 2 studies demonstrating absence of any neurobehavioral differences with the tricyclics versus Prozac in exposed versus non-exposed children. That study was done a while ago, with Prozac being a popular choice early on in treating depression in pregnant women. Children 1.5 to 6 years exposed to antidepressants in utero had similar IQ, language development, behavioral development, temperament, mood as those not exposed. And there was no difference between those exposed during just the first trimester or throughout the pregnancy. However, we do know that the clinical literature identifies that depression in mothers is associated with lower cognitive and language development in children if the mother has untreated depression. I want to talk a little bit about mood disorders and what to do with moms who or women who want to become pregnant who have bipolar disorder, who are just not sure of how they're going to manage their mood symptoms during pregnancy. Most of the commonly used anti-manic agents are either known teratogens or there's very limited available reproductive safety data. But we do know what the risks of untreated psychiatric illness are on moms during pregnancy, and the risk of discontinuing maintenance psychotropic medications during pregnancy all increase the risk of obviously psychiatric illness during pregnancy. The good news is that there are so many atypical antipsychotics now that we're using as mood stabilizers that we've really been able to move away from the old anti-manic agents, which are mostly anticonvulsants. But one, lithium, which is a wonderful mood stabilizer, and lithium actually is a wonderful antidepressant. It's one of the few mood stabilizers that what we call treat from the top and the bottom. It treats depression and mania. And what we've also known is that for many, many years we were told absolutely no lithium during pregnancy because of the risk of Epstein's anomaly, which is a cardiovascular malformation. The truth is that the relative risk is really quite low, the absolute risk versus the relative risk. And I have maintained moms who have been stable on lithium for years during pregnancy on lithium. And what did that involve? Of course, we had a cardiac echo, and the mom was followed in the high-risk clinic. But she was so stable on lithium, the risk of, and she had a very long history of instability and non-response to other medications. She actually had one baby and very quickly got pregnant, not necessarily intentionally, and was pregnant with twins while she had an infant, and remained on the lithium during the first and second pregnancy, and did very, very well with no relapse. I also didn't have to increase her medication. Now, Depakote, or valproic acid, is really the drug with the highest risk for all major malformations. Why is there so much information on the anti-mania drugs, especially the old ones? Well, because they're anticonvulsants, and as we know, you can't take a client, a woman with a known seizure disorder, off seizure medications to have a baby. The truth is, I don't think we should give Depakote to any women in the reproductive years because of the risk of major malformations, but also, as we know, with carbamazepine and Depakote, not with Lamictal, which is Lamotrigine. It also interferes with hormonal birth control. It makes it less effective. So if you have a mom on one of these old anti-mania drugs like Depakote or carbamazepine, using oral birth control can be problematic and cause for unintended pregnancies. The use of Lamictal actually works in the opposite direction. If we are on Lamictal and taking an oral contraception, the dose of the Lamictal may need to be increased versus the opposite with Depakote and carbamazepine. But utilizing Depakote during pregnancy would be the only drug out of all 115 psychiatric medications that exist that I would not use during pregnancy. And if the mom was on it, I would switch and stabilize mom if possible prior to pregnancy, if she was in the pre-pregnancy planning stages. And if she came to me during pregnancy on Depakote, I would wean her off. And actually, there's been studies looking at. There was one study that looked at 3-year-old children of moms who took anticonvulsants, and that Depakote exposed babies had IQs lower than the Lamictal. Now there were other factors, but when they controlled for them, the Depakote exposed babies still had a lower IQ. And that there are several studies that suggest Depakote exposure is associated with an increased risk for adverse cardiac and neurodevelopmental effects compared to using for other anticonvulsants. That being said, there are so many good options for mood stabilization that Depakote should really be avoided in women of reproductive age in general. The American Academy of Neurologists also recommends using against the use of Depakote during pregnancy. We know that there's an increase in a number of fetal malformations. There's some evidence of Lamictal in monotherapy causing an increased risk in oral clefts. Again, the absolute risk remains small. Lamictal, so oftentimes I don't start Lamictal if I have to add it to treat either depression or mood stabilization. Actually, Lamictal is very good for depression. I try to avoid starting it until after the anatomy scan. Although, again, if I had a mom who came to me on Lamictal, I wouldn't take them off. We would just want to inform them of the very, very slight increased risk for oral cleft issues. Now, when we think of antipsychotics, and again, you're not, antipsychotics are not only used for formal thought disorders, they're also used very, very commonly for mood stabilization. And we've been using typical antipsychotics, the old school antipsychotics, Haldol, paliperidone, Navain, for years, since the 1950s, most commonly Haldol during pregnancy, since the 1950s to help women who do have histories of schizophrenia or other psychotic disorders manage psychosis free during pregnancy. But now with the number of atypical atypical antipsychotics that are available, because the side effect profile of the atypicals, specifically the movement disorders, are less, it makes more sense to use the atypicals than the old typical antipsychotics. And as we see from some of the atypicals, there were not significantly any difference in any malformation between the different atypical antipsychotics. Infants exposed to atypical antipsychotics are more likely to be large for gestational age. This shouldn't be surprising. We know about the increase in weight and metabolic syndrome in someone who uses atypical antipsychotic drugs just in general. But the reproductive safety of these agents is limited to what we have currently available, but we don't have any evidence of teratogenicity based on the evidence that we do have. So really, again, for mood stabilization, use of atypical antipsychotics and Lamictal versus any of the old mood stabilizers is preferred. I wouldn't start someone on lithium if they didn't have a history of being stable on lithium before pregnancy. I don't think that we need to choose that option when we have other options with less risk available to us. The antipsychotics do have a black box warning about abnormal movements and withdrawal symptoms to infants who are exposed during the third trimester. Most of the EPS or the withdrawal symptoms resolved within hours of birth without treatment. Some required longer hospital stays, but for the most part, we didn't see EPS or movement disorders in children who are born whose moms were taking atypicals, because the movement disorders on the atypicals is less than the movement disorders on the typical antipsychotics. Typical, like I said, the typical antipsychotics have been used in pregnancy since the 50s. And we want to just be aware of the potential for adverse effects. And again, with all medications, we are introducing the moms to the important information about the risks versus the benefits of being on these medications, and helping the moms make informed decisions based on the clinical evidence that's available to us. What about benzos use during pregnancy? Really, there's a very slight increase in oral clefts with first trimester exposure, and in most of the studies that were done, these weren't these were animal studies, and they were exposed to very, very high doses of benzodiazepines. I've had anecdotally, I had a mother who had she was being treated by a clinician, and she had been on 6 milligrams of Xanax a day for a number of years and had been treated through her entire pregnancy on 6 milligrams, and came to me in the third trimester after her provider left the position he was in, and she no longer could get the Xanax, obviously, because other clinicians were hesitant about continuing her on it, but obviously by the 3rd trimester of pregnancy, there was nothing that I was going to do to try and get her off of it. And the goal was to sort of look at weaning her postpartum, and that dose we did see a fairly floppy, sedated baby, but the baby was perfectly fine and did not go through withdrawal. The mom did nurse the baby, and that probably helped the baby wean off the Xanax after birth. Mom was able to wean off the Xanax over time, over about a 2-year period postpartum. Anxiety is also a risk factor for preeclampsia, preterm labor, low birth weight, PPD, long-term behavioral cognitive developmental and medical problems in the exposed fetus. So treating anxiety, and oftentimes when mothers are used to taking Xanax or Klonopin PRN maybe 4 to 5 times a month, and feeling and very nervous that they would have to stop doing that during pregnancy. I tell them they don't have to stop doing during pregnancy. Certainly we'd like them to try other coping mechanisms, but if they absolutely need the benzodiazepine, the low dose benzodiazepine during pregnancy, we encourage them to do so. So which medication or which antidepressant is the best for pregnant moms? The truth is, the one that is most likely to be effective is the best. So if someone is on an antidepressant and they're doing well, then that's the antidepressant they should stay on during pregnancy. And as the provider, our job is to review with them the clinical data that we have available to us regarding the risks of taking that medication during pregnancy and help them make an informed decision. But recognizing that if we have to, if they really want to switch antidepressants during pregnancy, there's a risk that they may not respond and we'd have to put them back anyway, therefore exposing the fetus to more than one drug during pregnancy. If the mother isn't on an antidepressant and needs to go on one, then obviously we would begin with the antidepressant that the patient has responded to in the past. All SSRIs are secreted into the breast milk, but there are no serious adverse effects in association with this. There's some mild anecdotal reports of mild adverse effects that are possibly related to exposure to the drugs through breast milk, and that may be sedation or irritability. The only time I would say that caution is needed is if you have a very premature infant with some hepatic immaturity. But again, if the infant was exposed during the pregnancy, then worrying about that, because the crossover into the breast milk is much lower than the crossover during pregnancy. So the risk is, it makes absolutely no sense to switch them to a different medication while they're nursing if they've been on a medication during pregnancy. All right. And when we talk about crossover, moms always want to know what the lowest crossover in the breast milk is, and the lowest crossover is a Zoloft and Luvox with a somewhat higher level of crossover with Paxil, Prozac, and Celexa. But as I always say to moms, there's no evidence that any negative effects would occur by exposure to any of these medications. So what is the difference in the level of crossover? And there's no reason to check infant serum levels of these drugs in moms who are nursing. Using benzos and hypnotics during lactation, again, when measured, exposure for the breast milk is extremely low. There's some anecdotal reports of sedation. The reason why we worry about sedation in a newborn, obviously, if they're sleeping, they're not eating, we need newborns to gain weight. So we try and use those benzos with the shortest half-life, so they're less likely to accumulate. Valium is the more likely to accumulate because of its very, very long half-life. I don't encourage any of my moms to pump and dump because it's just not an exact science. And then especially moms who are obsessing to begin with, asking them to pump and dump only increases their anxiety. The only time and again, in using low-dose benzos, especially in those first 2 weeks postpartum with new moms with histories of anxiety, using low-dose benzos, PRN, is very helpful in getting them to just take the edge off for those first 2 weeks. And the only time I would hesitate is if they had a very preterm baby who, again, I'm worried about sedation if they're nursing, and I'm worried about the baby gaining weight. Those are the only times. So I always say, as long as the baby's at least 6.5 to 7 pounds, it's not something I worry about because I use very low dose benzos to begin with.
Dr. Kelly?
Yes.
As you requested, I'm just letting you know it's 12:40.
Perfect, and this is my last slide, I think. So I can certainly answer some questions. So in conclusion, pregnancy puts women with a history of depression or psychiatric illness in general at a higher risk of recurrence. It is not protective, as we know. Pregnancy is not protective against mental health issues. Pregnant women stable on medications need to be aware of the relapse risk if they decide to stop the medications. And this should be discussed when weighing the risk-benefit of using medications during pregnancy. Just quickly, the relapse of bipolar disorder during pregnancy. This was an interesting study that looked at 89 women with stable bipolar disorder 1 month prior to conception. 62 continued treatment, 27 discontinued. Of those that discontinued, 85% had a mood episode after they discontinued, versus only 37% of those who continued treatment. So when you think about that, those who discontinued treatment spent 40% of their pregnancy in an illness state versus those who continued who only spent about 9% of their pregnancy in an illness state. So when you see numbers like that, that's really a significant reason to help moms maintain treatment during pregnancy. So I'm now happy to answer any questions.
So we're having a little bit of an issue with the chat, but one question that I had is, I'm familiar with TMS, but I'm not sure that the other attendees are familiar with it as a treatment for severe depression. Could you talk about that for a little bit?
Absolutely. So transmagnetic stimulation is actually exactly what it sounds like. It's non-invasive. It's safe. You put sort of a cap on, and you have magnetic stimulation to specific areas of your brain, and the improved neurotransmission of serotonin with the transmagnetic stimulation decreases symptoms, but it requires treatments every single day. So that does make it a little difficult, but not impossible. But you do have to go every single day for it. And insurance does cover it now. The client that I have her insurance is paying for it.
Well, that's great that insurance is now covering it.
It doesn't have the side effects of ECT, the memory loss, that sort of thing, and it doesn't require any pre-medication. You can drive yourself there. There's no downtime. Doesn't require any sedation.
I can see one other question, and that is there any research on the use of these medications by the father and their effects on the baby?
That is such a great question, and there is very little research available. So, but the research that is available is mostly on the SSRIs, and no negative effects. But that's a great question.
That is the end of our questions, Dr. Kelly.
Well, thank you so much for me, and another plug to the PMAC Center. Please feel free to send your moms who are trying to decide whether or not what to do. And if they want to get pregnant, we do pre-pregnancy planning. We're happy to meet with moms and talk about medications before they get pregnant. So that's a perfectly appropriate use of our services.
Thank you very much for speaking today. I'm sure we all learned very much from you, and we appreciate your time. And thank you for attending.
Thank you very much.